Hi, welcome to the VCCC breast tumour grand rounds. My name is Britt and I lead a lab here at Peter Mac working on breast cancer and prevention. I'm going to be your MC for today's VCCC breast tumour grand rounds. As you might know, this is a fortnightly event and it showcases the latest developments in breast cancer related research locally, nationally and globally. First up, I would like to acknowledge the traditional custodians of the land on which myself and today's presenter is located, and I would like to pay respects to the elders both past and present and extend the respect to other Indigenous Australians that may be present online. As you might be able to hear, I'm going to do a blanket apology for the 10-month-old, 8-month-old screaming in the background through today's presentation. I would like to remind you that in accordance with the COVID precautions, the VCCC breast tumour grand rounds will only be available via webinar for further notice. So please make sure that you check the VCCC website for our upcoming events. And if you have any questions for today's presenter, you can do this via the GoToWebinar platform. And please do this throughout the presentation. I think if you're like me, you might think of a question as we go through the seminar, and then immediately when the speaker finishes, you've forgotten the pearler question that you were going to ask. The beauty of these digital seminars is you can ask them to me throughout and then I'll save them and I can ask our speaker right at the end. So make sure that if you have a question, you put it through the GoToWebinar platform. So today, our presenter is Dr. Raymond Yip. He is a Postdoctoral Fellow in the Breast Cancer Laboratory, which is co-head by Professors Jane Visvader and Jeff Lindeman at the WEHI. He completed his PhD at the University of Hong Kong before WEHI in 2017. And he was an attendee in the renowned embryology course at the Marine Biology Laboratory. During his training, he's translated his experience in skeletal development to study the role of bone microenvironment in skeletal metastasis of breast cancer. So Dr. Yip will present his quantitative 3D imaging of vascular niches for disseminated mammary tumour cells in bone marrow, and also summarise the latest insights into the mammary tumour bone metastatic niche as it evolves during disease progression, and therefore be able to discuss really the therapeutic opportunities that might exist for targeting this metastatic niche. Thank you, Dr. Yip. Welcome for the presentation.
Thank you, Cara. So I can share my screen now. So thank you, Cara, for the kind introductions. So hopefully you can see my screen in here. So today I'll be talking about an ongoing project that we started about 3 years ago now. It's really trying to understand the breast cancer bone metastasis from the perspective of niche regulations. So I think there's no need for me to introduce to the audience how common breast cancer is worldwide. Metastasis is the most important long-term determining factor for long-term patient survival outcome. And amongst the different organs, the skeleton is the most common site of breast cancer bone metastases. And in fact, 7 out of 10 patients with advanced breast cancer will develop bone mets. And they could happen really in any part of the skeleton, but they're most commonly found in the hip, in the skull, in the spine, and also in the long bones. And while bone mets is not as lethal as metastasis to the lung or to the liver, but they are a major cause of morbidity. And because when tumor cells invade into the bone marrow, they would cause a substantial reductions and destruction of the bone. And associating with these bone destructions, this means pathologic features and reduced mobility for the patients. And this greatly impacts their quality of life. And currently, most of the treatment that are given to bone met patients are mostly palliative, meaning that they do not actually directly target the tumor cells inside the bone marrow, but what those drugs do is actually to inhibit the activities of bone-degrading osteoclasts. And in saying that, hopefully that would attenuate bone degradations and alleviate some of the symptoms. And therefore, bone mets today remain still an incurable conditions. And definitely there's a unmet clinical need for us to develop new therapeutic strategies to treat bone mets. And to really achieve that, we need to have a full understanding of how cancer metastases arise. And one of the most simple yet elegant theory is seed and soil theory that was proposed by Stephen Paget now over a century ago. So it's actually a very simple concept about seed and soil in terms of the gardening. So I guess some of us are doing a little bit more gardening nowadays, and because of the lockdown. So really what this theory is about is that if you wanted to grow a plant, you really need quality seed and fertile soil both at the same time. So imagine if you have the most amazing seed, but you're planting them into the very dry soil on the left, you will not have a very, very high chance of getting a plant. And vice versa, if you have the most fertile and nutrient-rich soil, but then you have really poor seed that have been improperly stored for years, then likewise, you will not have a good plant as well. So it's actually really take the combinations of both the seed and the soil quality to determine the success of growing a plant. And really the same rules apply to cancer metastasis. So meaning that for the cancer cells to exit their primary organ and to colonize a foreign organ, the successful of that transitions really depends on the intrinsic factor of the tumor cells, which are known as the hallmarks of cancer. So this, as we all know, involved their ability to resist cell death, their ability to sustain proliferations, and evade growth suppressors. But at the same time, the success of their colonization, it's highly dependent on the microenvironment that they are locating. So you could imagine that when the tumor cells exit from the primary tissue, in this case the breast tissues, they would have to transit into the bone, and they would face a whole new suite of neighbors and cytokines that they're not adapted to encounter. And in this case, you could imagine that the microenvironment and the availability of nutrient in that foreign organ would determine whether the tumor cells would successfully colonize the organ. And when talking about bone mets, when the bone metastatic cascade can be described as follows. So usually it really starts off with the malignant lesions at the primary organ, which is the breast in this case. And a subset of these tumor cells would have the ability to invade into the blood or lymphatic vessel systems and to metastasize to foreign organs. And they usually arrive at the target organ as either a single or a small cluster of disseminated tumor cells. And after they successfully land into the foreign organ, now they would have to make the decision whether to initiate proliferation to become a micromet, or they could decide to enter into dormancy. And this transition is entirely reversible. And upon the appropriate signals or nutrients, then the microscopic lesions would start to expand and to become a micromet. And it is usually during that point where clinicians are able to pick up the lesions from radiography, and then they could start giving the treatment to the patients. And while most of the tumor cells facing the treatment would undergo cell death, a tiny portion of those tumor cells may have the opportunity to survive through the treatments and persist and reverting back to the disseminated tumor cell stage. And this is what we always known as the minimal residual disease that is very clinically challenging. And over the past decade especially, there is a growing body of evidence to suggest that this particular aspect of bone mets, it's largely influenced by the local microenvironments of the bone rather than the intrinsic factors of the tumor cells. So if we zoom in more to this niche regulated cascade, this pathway could be roughly categorized into 3 different stages. So the stage 1 is called the seeding and survival. So it is becoming increasingly clear that the tumor cells, when they disseminate into the organ, they do not distribute randomly across the bone marrow. And in fact, they would preferentially seed to specialized compartment or niches of the marrow that favor their colonizations. So those apartments could be rich in nutrients, could be rich in oxygen, and could provide protective physical barriers to immune cells. And one of the more well characterized components of the bone that interact with the disseminated tumor cells are the osteoblasts. So it has been described that tumor cells, they physically contact osteoblasts via the coherent junctions. And in doing so, that would activate the intrinsic survival pathway. And in parallel, the tumor cells could also receive 6cell12, for example, some of the molecules from the surrounding stroma component to activate their intrinsic survival pathways. And in parallel, disseminated tumor cells develop a very cunning strategy to downregulate interferon pathway to evade immunosurveillance, such as attack from NK and T cells. So all the strategies allow them to successfully survived the initial landing stage. So having survived the initial stage, now they would have to face a decision whether to undergo proliferations or to enter dormancy. And this decision is largely regulated by the interactions between the tumor cells and the local microenvironment. So taking prostate cancer as an example, it has been shown that the tumor cells would physically interact with the bone lining cells to induce dormancy. And in the case of breast cancer, it has been shown that the stability of the blood vessels and some of the endothelial-derived factors would regulate the breast tumors dormancy and relapse. And not only cell-cell interactions, microenvironmental changes such as hypoxia has also been shown to control some of the pro-dormancy genes. And therefore, it's actually the cell-cell interaction as well as the microenvironment changes really greatly determine the decisions to undergo proliferations or dormancy. And then having really developed into the micromet, now if they decide to go further to expand into a macromet, they would usually initiate what we now know as a vicious cycle. So what it actually does is that the tumor cells would secrete different factors such as PTHRP, interleukin-6, and different molecules that directly target osteoblasts or osteoclasts. In doing so, they would disrupt the normal bone remodeling process. And ultimately, this would induce excessive bone degradations. And in doing so, the release of the bone-bound molecules such as TGF-beta would then feed back to the tumor cells to improve and foster proliferations. And this would establish a feed-forward cycle that basically exacerbate the progressions of bone mets. And at the same time, while they're still going to proliferate, they also would interact with the bone marrow stromal component to protect themselves against chemotherapy or other drugs. So it has been shown that chemotherapy would induce JAK1 expression in osteoblasts, and the interaction between the osteoblast and the tumor cells would then engage and activate Notch signaling to confer chemo resistance. And likewise, it is also recently shown that the bone marrow perivascular niche would also confer chemo resistance to the tumor cells through integrin-mediated signaling. So altogether, this evidence implicate complex and constantly evolving interplay between the disseminated tumor cells and the local microenvironments during bone colonizations. And characterization of these interactions could inform new therapeutic strategies to treat bone metastases. So while I've actually mentioned the different interactions earlier on, but a lot of those conclusions and report on DTCs and niche interactions was basically inferred from co-culture assays or visual identifications from narrow fields of views in the tissues. So you can imagine that we're only taking a snapshot through the vast 3D space from here and here. We'll be missing a lot of the information in between the two sampling points. And indeed, a global quantitative analysis on the distribution of the tumor cells within intact bone marrow space are still largely lacking. So to address this research gap, we established a pipeline to achieve high-resolution 3D imaging of mouse bone marrow. So what we did is that we generated thick cross-sections that could be basically of any thickness. And then we also implement optical clearing so that could improve our resolutions and imaging depth. And we utilize this technique to basically analyze the DTC niche interactions across metastatic stages in situ. And hopefully we could understand what sort of components are interacting with the tumor cells, and are they functional interactions, and can we infer something or detect some molecular target that could be therapeutically targeted. So to achieve that, we have been using a 41.2 mouse model. So this particular mammary mouse tumor cell line is very unique in a way that it can undergo spontaneous metastasis from the primary site to the target organ, in this case the bone, within a relatively short time frame. And all this metastatic process happens in a syngeneic setting, meaning that we could evaluate the immune cells during this metastatic cascade. And by implementing the 41.2 and the imaging technique, by combining the two, so we're able to perform 3D imaging that accurately identify, you could see individuals or tiny clusters of the disseminated tumor cells across the bone marrow space. And to really highlight the spatial resolutions that we could get from this technique, so I'm going to show you a movie that really runs through the bone marrow samples over a depth of almost 200 micron in thickness. And what I wanted to draw to your attention is that you could see that there are minimal loss of fluorescent intensity as we go deep into the tissue because of the optical clearing technique. And also you could see that the vessel lumen as well as the continuity of the vessels were excellently preserved during this protocol. So meaning that the microarchitectures are preserved and we could detect the tumor cells in their most native environment. And because now we're imaging the samples in 3D, so we also implemented the use of random distributors to achieve unbiased quantifications. So what I mean is that from our experimental data, if we wanted to test whether the tumor cells, for example in here, are they significantly close to the blood vessels or to other cell type of interest, we would also spike in some simulated data spot that matches the tumor sites. And then it basically gives us an internal control within the same 3D space. And then we could perform statistical tests to confirm whether there are any spatial dependency or different spatial affinity between the tumor cells and cell type of interest. So first, we focus on the two major bone marrow niche in the bone, which are the osteoblastic and the perivascular niche. So in this case, we labeled the bone marrow sample with collagen 1A1 antibody. So that's basically outlining the bone in gray in here. And we also highlight the blood vessels using CD31 antibody that is shown in green in here. And if you look close in here, you can see also tiny dots of disseminated tumor cells in here and in here as well. So it really highlights the spatial resolutions that we could achieve with this technique. And next, we measured distance between the disseminated tumor cells against bone and also against the blood vessels. And what we found is that compared to the random samples, so compared to the random simulated data spots, you could see that there's not much difference between the disseminated tumor cells and the random spot localizations. But by contrast, what we observed is that around 70% of the disseminated tumor cells are located within 10 micron of a blood vessel, implicating a direct interaction between the tumor cells and the vasculatures. And this was also further highlighted in this three-dimensional rendering movie. So, lost my rising. Yeah, so it's coming on. Yeah, so in this movie, basically, the blood vessels are stained by CD31, and it's shown in gray in color, and then the tumor cells are labeled in yellow in here. So this 3D rendering really highlight that you could see there's intimate cell-cell intimate connections between the tumor cells and the bone marrow vasculatures. So you can see, for example, this particular tumor cell is actually sort of crawling along the blood vessels. And again, you can see that the lumen of the blood vessel remain open, meaning that the tissue microarchitectures was excellently preserved in here. So having established there is a intimate cell-cell interaction between the tumor cells and the vasculatures, what we did next is to really look at the different subtypes of bone marrow vasculatures. Because we know that the vasculature in bone marrow can be divided into different subtypes based on their expression level of endomucin and CD31. So what we did is that we performed a colocalization analysis on the images. So as you can see in here, the blood vessels in cyan here it's CD31 positive and endomucin negative. we then create a unique surface for this particular arterial vessel subtype. And likewise, we separated the type H and the type L vessels based on their differential expression level of endomucin and CD31, and they are represented by different surfaces on the right. And at the same time, we also transform our disseminated tumor cells into magenta spot in here. So what we did next is to really measure the distance between the individual tumor cells against the different blood vessel subtypes, and to look at whether there are differential affinity towards blood vessel subtype. So what we found is that in the case of arterioles, we couldn't see any preferential association of tumor cells with the arterioles. But instead, what we found is that the tumor cells are preferentially situated further away from the sinusoid, but the majority of those tumor cells, they preferentially disseminate near the type H vessels. And all this this is against the random spot, meaning that this localization is significant. And indeed, when we switch to a different injection approach, such as intracardiac injections, so in here the tumor cells are directly introduced into the circulations by the intracardiac route, and so it bypassed the primary tumorigenesis stage. But even in that approach, we could see that the tumor cells, they preferentially disseminate near type H vessels, and this is very significant compared to the random simulated data. And because of this, so we speculate that the type H vessels may appear to be the site of entry for breast tumor cells when invading the bone marrow. So the question is, what is special about this particular blood vessel subtype? So we sort of get some idea from our imaging data. So first of all, we imaged a Core2.3 CFP transgenic mice. So in this transgenic mice, all the osteogenic cells are labeled by the CFP protein in here. So you could recognize the classical osteoblasts lining the bone surface and the osteocytes that are embedded within the bone matrix. But at the same time, we could see that the type H vessels are the exclusive vessels that are coated by a layer of CFP positive osteogenic cells. So meaning that the type H vascular niche is not only simply a vascular niche, but it's more of a hybrid of osteogenic and vascular niche. So you could imagine that the tumor cells, when they enter into the bone marrow via this type H vessels, they would also receive environmental signals from both the osteogenic component as well as the endothelial components. And the second piece of evidence that we also managed to get is that we found that the type H vascular niche, it's more permeable than other blood vessel subtypes. So meaning that there could be less physical barrier for the tumor cells when they extravasate from the blood vessels. And on top of that, a couple of studies have also demonstrated that the type H vascular niche has privileged access to oxygen and nutrients. And importantly, there is a lower blood flow rate and also the lack of collagen IV basement membrane coverage. So meaning that tumor cells would have a higher chance and more time and also less barrier when they try to extravasate from the blood vessels and enter into the bone marrow. And because of the privileged access to oxygens, there are also less reactive oxygen species. And it has also been shown that the type H endothelial cells, compared to other endothelial cells, they are the one that produces stem cell factor and RANKL, both of which has been shown to be important for tumor cell behavior. So after characterizing the initial colonization stage, we next move on to really use the technique to examine the later stages of bone metastases. So what I'm showing here is a typical tile scan of the entire femur. So straight away you can see that there are two microscopic lesions in the femur. So one near the metaphysis at the head of the femur, and then a giant lesions at the center of the long bone shaft. And what we notice straight away is that there's a pronounced changes in the vasculature at the metastatic lesion sites. So if you look at here, so compared to the tumor-free adjacent non-met area, you can see that the vasculatures in the metastatic lesions area, they highly upregulated endomucin and CD31, and they also appear to be highly disorganized. And this upregulation of the two vascular markers was also confirmed by measuring the phospho signal intensity in these images. And apart from the upregulations of CD31 and endomucin, we also noticed that the vasculatures in the metastatic lesion site have a very distinct morphology. So compared to the adjacent non-met regions, where you can see that the blood vessels have a relatively smooth outer surface, the vasculature at the metastatic lesions, they appear to be disorganized, upregulated endomucin and CD31, and also they appear to be unusually barbed. And indeed, when we generated three-dimensional rendering of these blood vessels in these two regions, you could also appreciate now that the non-metastatic vessels, they have a smooth surface again, and you can observe also sprouting happening in the vasculatures at the metastatic lesions. And this sprouting effect could be measured as an increase in blood vessel surface area over length. And because now we're imaging the bone marrow sample in 3D, we could render and slice open the blood vessels, as in here. So when we look at the optical sections of the metastatic vessels, you could see that the lumen size is comparably smaller and shrunken compared to the non-met vessels. And again, you could see the sprouting and projections happening on the endothelium surface. And we also found is that this vascular sprouting effect is not only regional, but it also only affects a subset of blood vessels. So as you can see in here, the arterial vessels that are CD31 positive but endomucin negative, they were not affected. They do not undergo sprouting effects, despite all the adjacent blood vessels undergo sprouting and undergo remodeling process. And part of the reason is that those CD31 positive endomucin negative blood vessels, they are coated by a layer of parasites, as in here. So you could see that this particular blood vessels coated with alpha SMA is not undergoing sprouting effects compared to the adjacent vessels. So the sprouting effect is only affecting the non-arterial vessels. And we also stained the samples with cleaved caspase 3 and Ki67 as well as EDU. And what we found is that we did not see any aberrant changes in these markers, suggesting that this sprouting remodeling effect does not involve abnormal proliferations or apoptosis of endothelial cells. And what is really important is that all this sprouting and remodeling effect, it's only happening in regions where there are tumor infiltrations. So you can see that all the remodeling effect, it's highly spatially restricted, suggesting that there is a close range interaction between the tumor cells and the endothelial cells that drive this abnormal vasculature changes. So to identify molecules that mediate the tumor cell vasculature interactions, what we next did is that we FACS isolated endothelial cells from the metastatic regions, and also we collected endothelial cells from the adjacent non-met regions of the same bone, and we FACS collect the endothelial cells for RNA-seq to aim to identify what sort of pathways or molecules are upregulated. And what we found is that by performing Goldham analysis on the D genes, what we found is that a lot of the biological pathways that are up in the metastatic endothelial cells were related to blood vessel morphogenesis and development of the vasculatures, as well as migrations for leukocyte and neutrophils. And what we also did at the same time is that we also performed RNA-seq on the 41.2 cell line, as well as the non-metastatic sibling cell lines, such as the 67NR and 66L4. And then we also particularly focus on genes that are known to play a role in angiogenesis and leukocyte migration pathway. And one of the genes that caught our eye is CSF3 that encodes for GCSF. So you could see that the GCSF gene is highly expressed in the 41.2 cell line as well as the 41 cell line, but it's minimally expressed in the non-metastatic cell lines. So the next experiment that we did is that we injected the 67NR that minimally expressed CSF3 into the mice and looked at the vasculature in the bone lesions. So in comparison to the 41.2 induced bone lesions, you could see that the 6-7L induced bone lesions, they do present disorganized blood vasculatures, but they do not show any sprouting effects. And at the same time, we also inject MDA231, which is a human triple negative breast cancer cell line, into a immunocompromised mice. And in this case, the MDA231 cell line is known to minimally express GCSF. And similarly, you can see that the vasculatures in the metastatic lesions are highly disorganized as well, but they again do not present any sprouting effects. And what is important also at the same time, we also notice that the endothelial sprouting is not due to physical insult to the vessel wall. So you can see that in this area where there's a huge amount of infiltration of tumor cells, the vessels appear not to undergoing any sprouting effects, meaning that the sprouting is not due to damages to the vessel wall or microenvironmental changes, such as MET-induced hypoxia or necrosis. And because GCSF it's a very well-known chemokine that induces neutrophil mobilization and expansion. So we are hypothesizing maybe that GCSF that is secreted from the tumor would stimulate neutrophils, and neutrophils in turn causes the endothelial remodeling effects. So to address this possibility, what we next did is to do a neutrophil depletion in the metastasis-burdened mice. So we basically inject intracardiacally the tumor cells and then wait for a week for the MET to happen, and then we treat the MET-burdened mice with the isolated control or anti-Ly6G antibody to deplete neutrophils. So as expected, the anti-Ly6G treatments efficiently suppress tumor-induced expansion of neutrophils in both the peripheral blood and also in the bone marrow. But what we saw is that when we imaged the vasculature in the metastatic lesions, we could see that the endothelial sprouting and remodeling effect persist in the presence of anti-Ly6G treatment. So we also quantitatively measured that the blood vessel surface area of the length as well as the sprout length remain comparable between the two treatment groups. So this data suggests that the neutrophils may not be the mediator of the endothelial sprouting effects, and it could be that the tumor cells are directly remodeling the vasculatures. So to directly block GCSF activity, we obtain the anti-GCSFR blocking antibody from CSL that specifically block GCSF signaling. So what we then did again is to basically intracardiacally deliver the 41.2 cells into the mice and waited for a week for the metastasis to occur. And then we started treating the mice with anti-GCSFR or the isolated control. And as expected, the anti-GCSFR would abrogate GCSF signaling, and therefore the enlargement of the spleen was reversed upon the treatment. And also when you measured the neutrophil populations in the peripheral blood, you could see that compared to the control, the anti-GCSFR effectively suppressed neutrophil mobilizations and expansion. And at the same time, it also suppressed the maturations of the neutrophils. And what we found is that upon anti-GCSFR treatments, this treatment alone could attenuate vessel sprouting. As you can see in here, that the sprouting frequency it's suppressed upon the treatments. And we also quantitatively confirmed that by measuring the surface area of the length in the blood vessels, and also the length of the sprout was also decreased upon the anti-GCSFR treatments. But there were no significant changes in terms of the coverage and the vascularity in the metastatic lesions, but and also the lumen area of the blood vessels remain shrunken. So meaning that the anti-GCSFR treatment partially normalized the metastatic vasculatures in the bone lesions. But rather disappointingly, when we look at the frequency of the bone metastases, as well as the severity and the size of the bone mets between the two treatment groups, we could not see any significant differences. So meaning that even we could partially normalize the vasculature at the metastatic lesions, it is insufficient to eradicate the advanced bone lesion development on its own. So that leads us to the subsequent experiment is to ask the question whether the partial normalization of the metastatic vasculature could that sensitize tumor cells to chemotherapy. So to test that hypothesis, we go back to the orthotopic transplantation model in here. So what we did is basically transplant the 41.2 cells into the mammary gland of the mouse, and then we wait for a week for the tumors to develop, and then we started to give them anti-GCSF in combinations of docetaxel or vehicles, and we collect the mice at ethical endpoints. And again, as expected, the anti-GCSF treatment alone would effectively suppress neutrophil expansions. But interestingly, the addition of docetaxel somehow attenuates the neutrophil suppressive effect of anti-GCSF. More interestingly, what we found is that the anti-GCSF treatment on its own would achieve a comparable extension of survival in tumor burden mice to standard chemotherapy. So particularly when you look at the primary tumor volume, you could see that the anti-GCSF mono agents and treatment alone could also reduce the tumor progressions, and it also prolonged the survival of the tumor burden mice. And because we're not collecting all the mice at the same time, but if you look at the ethical endpoint in here, you could see that the anti-GCSF treatments on its own, they effectively suppress metastasis to the bone. And when we image the bone lesions, you could see that comparing to the docetaxel or compared to the vehicle alone, you could see that the anti-GCSF monotherapy, they attenuate and suppress bone metastases. And finally, we also look at the primary tumor vasculatures. So what is interesting, what we found is that in the vehicle or in docetaxel alone treatment, we could see that the tumor vasculatures are very abnormal. So you could see that a lot of sprouting happening in the primary tumors. But the additions of the anti-GCSF on its own could effectively suppress the sprouting effects in the primary tumors. The addition of docetaxel doesn't seem to have any additive effects, so meaning that the blocking of GCSF signaling is sufficient to normalize primary tumor vasculatures. And we also confirmed that by measuring the surface area over the length, as well as the coverage, and also measuring the lumen area. So you could see that the anti-GCSF treatment on its own could normalize the primary tumor vasculatures, as well as the vasculature at the metastatic lesions. So in summary, I'll tell you that we have established a robust pipeline to image and analyze unbiasedly large volumes of intact bone marrow space. And what we also shown that it's by doing quantitative 3D imaging, we have gained spatial temporal insight into the mammary tumor bone metastatic niche as it evolves during colonizations. So what I described is that the tumor cells would preferentially disseminate near a particular blood vessel subtype known as the type H vessels, and as they expand, they would remodel the local vasculature to propel its further expansion. And what we, by doing RNA-seq analysis, what we identify is that GCSF, which is widely used in cancer therapy to reduce the risk of chemotherapy-associated neutropenia, it was found to have a pro-angiogenic role in mammary tumorigenesis. And we show that by using a loss-of-function approach by blocking GCSF signaling. And indeed, by blocking GCSF signaling, we found that it also normalizes the primary tumor vasculature as well as the vasculature in the metastatic lesions. And in doing so, it appears to prevent spontaneous metastasis and also enhances survival. So lastly, I also wanted to describe this technique a little bit more because I think it could be applicable to other people that wanted to image the bone microenvironments. So we have also been successful in translating this technique to image other bone components, such as the calvarium in here. You can see a very nice preservations of tissue microarchitectures into calvarium. And we also have been trying to do some multiphoton imaging using this technique on human autopsy bone marrow. So meaning that hopefully we could also see some clinical relevant phenotypes in the human sample as well. And the other assay that we've attempted, but I haven't had time to show you today, it's about identifying dormant cells in the bone marrow. So we have successfully combined this imaging technique with EDU staining. So by doing some EDU retaining assay, we could identify dormant disseminated tumor cells in the bone marrow. And our ability to image the samples in 3D, it's really important, as some of the dormant cells are very rare in the bone marrow. So at the end, I would like to thank Jane and Jeff for their very continuous and generous support and insight and guidance throughout the project, and especially giving me the freedom really to start the project and giving me a lot of support in this journey. I'd like to thank everyone in the breast cancer laboratory for their discussions and help and friendships, and especially to Bianca for doing the tissue culture work, to Francois who did all the transplantations and with the drug treatment. And I'd also like to thank everyone in the cancer biology and stem cell divisions, and particularly I want to acknowledge Edwin and his student Joe from the immunology divisions. So they have been giving me a lot of advice on the imaging technique. And I'll also thanks Gordon and Andy from the bioinformatics divisions for doing the RNA-seq analysis, and of course to all the staff in the bioservices for looking after the mice. And I'd also like to thanks Bupinda for making the RNA libraries, and also Robin for providing some of the reagents from the ONJ. I also like to thank CSL for generously giving us the anti-GCSF neutralizing antibody, and also to all the imaging histology effects and the BDO people at WeHi. So with that, I'm happy to take any questions. Thank you.
Thanks so much, Raymond. That was like absolutely amazing. The imaging was absolutely beautiful. I'm wondering if I can start off by asking some questions that have come through from the audience. So the first one is, what is the minimum number of disseminated tumour cells that you've been able to image to determine the very earliest interactions at the dormant micrometastatic stage? Because this is obviously important for determining localization near existing vessels versus new vessels post-angiogenesis.
So in terms of the spatial and spatial resolutions, we could image down to a single cell. So so some of the analysis, so we've been trying to sample a lot of bones, and sometimes you would see 1 or 2 cells, sometimes you would see 10 or 20 cells. But in terms of the spatial resolutions, we could image down to single cell, and that's an issue.
Okay, so the next question is, what was the impact of the anti-Ly6G on other non-metastatic organs, given that this model is associated with an unusually high accumulation of these cells? And did you have any toxicity issues?
I think in terms of the toxicity, we didn't really see it because it's actually just a 1 week very short-term treatment. So the treatment only lasts for a week. Because we deliberately intracatheterly inject the tumor cells into the heart, so that we could achieve bone met within a very short time. So we could limit our treatment within a week. So so we didn't see any obvious toxicities, but I have to say that we didn't purposefully collect other organs for imaging. Okay,
but you didn't see any mice issues?
Yeah.
No. Is there any information on tumour GCSF levels and bone metastasis in patient cohorts?
Yeah, I think this is something that we really want to emphasize. I mean, really want to collect as well. I think there's a very clear correlation between GCSF signatures and triple negative breast cancer, but we're not totally aware of any clear link yet. I think one of the issues is that GCSF has been used quite frequently in chemotherapy treatments. So, giving GCSF to patients might also sort of complicate and confound the study.
Yeah. Another question is, how do you confirm that the normalization of the vasculature via blocking the GCSF is responsible for the reduced metastasis rather than a secondary impact of reduced metastatic growth? So how does this work compare to that of, say, John Hamilton and Robin Anderson, who have reported the anti-metastatic effects of targeting GCSF?
Yeah, I think it's actually in parallel. So I think what Robin Anderson and other people have really beautifully demonstrate is that it actually affect the marrow-derived suppressor cells to suppress the pro-metastatic organ environments. So I think it's actually in parallel. So I think first of all, the treatment would definitely suppress neutrophil mobilizations, and in that case alone, I think that would explain the anti-metastatic effect. But what we think is that this study added in that way is that we also show that the treatment would also affect the tumor vasculature as well as the vasculature in the metastatic lesions. So I think it's actually sort of a in parallel combinations effect that reduces the metastatic burden. I think, and also what we really want to try to do is to inject GCSF into naive mice and to see whether that would be sufficient to induce the vascular sprouting. So, and then that would give us a more definitive answer whether GCSF alone is a instructive effect and instructive factor to drive vessel remodeling.
I guess I'll just ask the first part of that question again. How do you confirm that the normalization of the vasculature via blocking GCSF is responsible for the metastasis and not a secondary impact of reduced growth?
Yeah, I think we can't really say that. Definitely there is a reduction of growth, but I think the other way to do it is to maybe to intricatically inject the tumor cells so that it would sort of bypass the effects from the primary tumors. So I think another experiment that we intended to do is to, as I said, intricatically inject the cells, so we would avoid, we could exclude the effect from the primary tumors. And once the tumor cells have initiated the lesions, and then we can administrate the anti-GCSF.
One question while you're talking about that I'll ask is, you went through it too quickly for me to be able to sort of catch the data, but you looked at the decrease in the bone mets, but you had I think you had other metastatic sites up there. So was it a bone specific effect, or did you actually see it in other areas as well?
Do you mean in body imaging or?
So yeah, I think from the the slide was quite quick, but the anti-GCSF treatment that you did, you showed that there was a decrease in bone mets, but I think you had other metastatic sites up there that you analysed. Did they all show no change?
Yeah, I think so. It's actually, I think I have to emphasize that we did not collect all the mice at once. So it's actually we just collect them at the ethical endpoint. So I think in terms of the frequency of the metastasis, it's hard to draw a line based on this study, but we also did see a reductions in metastasis to the liver and to the lung as well by just using the anti-GCSF. And I think that has been confirmed by Robin Anderson's group as well.
Okay. Got another question from the audience. Sorry, I'm just catching up to where we are. Great talk, Ray. Which cells are being impacted by blocking GCSF signaling, and do the endothelial cells express GCSF receptor?
Yes, that's an awesome question. So the endothelial cells do express minimal amount of GCSF receptor transcripts. So that was picked up by our RNA-seq as well. So we're confident that they do express GCSF-R. So to really show that it is a direct interaction, so we did an experiment where we basically transplant a GCSF receptor knockout bone marrow to the mice and then give them GCSF. Hopefully, if it is a direct interaction between GCSF, if it is a direct interaction between tumor cells and the endothelial cells, so the GCSF treatment should still induce vasculature remodeling in the GCSF knock out bone marrow transplant mice.
Okay. Next question is, do you know how the bone marrow niche keeps the cells dormant, and do you think it's a kind of maintenance therapy that could be beneficial in killing these cells?
Yeah, I think the dormancy issue is really challenging, and I think, I mean, it's more well understood in the prostate cancer field in terms of the interaction between the tumor cells and the osteoblasts. But in terms of the dormancy for breast cancer cells, there has been evidence to suggest that the vasculature is the major mediator for dormancy, for keeping the cells in dormant. So that has been reported, but I think what our advantage in here is that we could image the bone marrow to a really deep tissue imaging, and so we could, analyze hundreds of dormant cells if we have the right systems. And I think the 41.2 model that we have been using largely, it has an issue is that it's just too aggressive. And so even when we do the EDU retaining assay, we could only pick up really a handful of EDU retained 41 cells. So it would be a very challenging just to use that cell line. So I mean, if anyone have any good mouse line model, I'll be so happy to have a look and to see whether we could pick up some dormant cells in the brain.
I was going to ask one question, and I presume it's only very early in that line of investigation, but you did say that you've been looking at the dormant cells versus the non-dormant cells using your imaging. Can you see anything in the immediate microenvironment where the dormant cells are compared to where the highly active ones are?
So we only focus particularly on vasculars. So we haven't been, I mean, we tried to do immune cells, and I mean the protocol works well for immune cells as well, but we have been mainly focusing on the osteoblastic and the vascular niche. So from that very preliminary analysis, we did not see any preferential association between the tumor cells and the vasculatures or the bone. So presumably they could be interacting with some kind of stromal cells that we just haven't started to look at yet. But again, we could only detect a really handful of 41.2 dormant cells. And as I said, I don't think the 41.2 is the perfect model to understand dormancy. And so, yeah, it's too early to say the conclusion.
Okay, and have you, I mean, I'm just wondering, have you tried looking earlier on in the process? One of the questions I was going to ask you is, how did you decide when to go in during the metastatic cascade, sort of, early on versus late on? Because some of the earlier images you showed were only really small metastatic deposits, whereas later on we can see those huge big metastases. So have you done more of a temporal analysis? And if you do it earlier on, can you see more dormant cells?
Well, in terms of the dormant, unfortunately, we haven't looked at the very early stage for dormant cells. So in terms of the, the early and late stage, what we did is that we sort of comprehensively collect mice, 7 days, 10 days, 14 days after the inoculations, so we could sort of know usually what stage are they in. But for the EDU retaining assay, we did not do that. We basically, pause the mice for 2 weeks, and then allow them to survive for as long as possible. So we didn't specifically look at the early phase of dormancy.
Okay. One of the other questions that's come through is, have you looked at the spatial relationship between neutrophils, myeloid-derived suppressor cells, and the bone marrow metastatic niche?
Not yet. So we have been we have stained the bone marrow samples with like NK, T cells, and macrophages, but we haven't really looked at the myeloid-derived suppressor cells yet. Okay.
I'll just put a call out to everybody that is in the audience to send through any last-minute questions you might have while I ask a couple. One of the things that you showed was the disorganization of the blood vessels in the metastatic areas and an increase in surface area. Do you know whether this happens prior to like the tumor cells or the metastases becoming situated there? So is it happening prior to the metastatic deposit being there and calling it in, or is it actually just as it grows, that's what's happening?
I think it's actually a consequence of the interaction between the tumor cells and the endothelium. It's just based on speculation, because I mean, you could see a really clear boundary between the metastatic lesions and the non-metastatic lesions. So I think it would be a very close range interactions, between the tumor cells and the endothelial cells. I mean, when we look at the naive mice, they didn't see any. I mean, I haven't really looked at the very early stage. I mean, we could look at a sort of a pre-metastatic microenvironment in that sense. Yeah, but we haven't done that yet.
Okay. A technical question that might seem a little bit silly, but when you were showing the awesome picture of the bone, and you've got areas of metastasis and areas of non-metastasis, and you took those and flow sorted them, and then were able to do the beautiful sequencing to sort of find the interaction with GCSF. How did you actually do that? So was it hard to actually get the metastatic areas versus the non-metastatic areas out of bone separately? Do you have some sort of tag on those cells that allows you to see them when you're dissecting?
Yeah, absolutely. So we have tagged the cells with red fluorescent protein. So I mean, it's actually quite handy. So basically, what we did is that we just put the bone under the stereo microscope, and then you could immediately see whether the regions of met and the non-met regions, and basically just chop separate the bones. And then what we then did is that I think the hardest part is about isolating the endothelial cells, which require a little bit of collagenase and digestions and all that, crushing. But yet, I think in terms of identifying the metastatic lesions, that the presence of the red fluorescent protein helps it a lot.
Yeah, that was beautiful. Thank you. So I guess one of the last questions that we have is it worth using a lipophilic labeling technique to track down dormant versus proliferating cells after your intracardiac injection?
As in labeling the dormant cells, or?
Yeah, to track the dormant versus proliferating cells is what the question's asking.
Oh yes, I think there's a maybe there was a Nature paper came out like a couple of months ago, and so I think they were using a very similar technique. So what the paper basically described is that I think they use another different breast cancer cell line, and they basically make the cell line to secrete some fluorescent protein, so that the secreted fluorescent protein would label all the neighboring cells and help them to identify the metastatic niche for dormant and proliferative cells. I think that sort of has been done, but I think what we really want to do is to find the perfect model in here, and to use our 3D imaging technique, which I think would be very beneficial in identifying those really rare and dormant cells.
Yeah. Okay, well, all that remains now is for me to thank you again for an amazing presentation. I'm sure everyone will agree it was absolutely jam-packed with some beautiful imaging and really awesome insights into what's happening in that bone metastatic niche. I also want to thank the audience for tuning in, for asking some really great questions. It was sort of really great to have you involved with that. I'll remind you to check the VCCC website for our next presentation, which is on Wednesday, the 29th of July, with Professor Martin Idrizaman, and I apologise about the pronunciation of that, but the details on that will be available soon. There are also a couple of places left for the inaugural Breast Cancer Fellows and Registrars Education Series, which is a monthly series that will focus on key issues of breast cancer management, including areas where there is a recent change and uncertainty. And so it's open for those training in breast surgery, radiation, medical oncology fellows and advanced trainees. So make sure you have a look at that. Thanks again for tuning in. We'll see you next time.